Okay, so now we'll be discussing about achalasia. Basically, what is achalasia? Achalasia is essentially failure of lower esophageal sphincter to relax. And why does this happen? It happens because of degeneration of the meandric nerve plexus, which is present in the esophageal wall, right? And selectively, the inhibitory neurons, which contain nitrous oxide and vasoactive intestinal peptide, these neurons are destroyed. Because of destruction of these neurons, there is failure of LES to relax, because of which the patient presents with symptoms such as dysphagia, difficulty in belching means burping, and chest pain. Okay, now achalasia can also happen because of degenerative changes in the extraesophageal vagus nerve or even the dorsal motor nucleus of the vagus. As we know, vagus nerve is the parasympathetic supply to the GIT, right? And because of vagus nerve only, this LES will relax. So basically, if this degenerates or the meandric plexus of the esophageal wall degenerates, there would be the failure of relaxation, right? Now, achalasia can happen due to primary reason or secondary reason. Primary reasons are basically unknown, so primary reasons are idiopathic. Secondary reasons might involve a very common infection by Trypanosoma cruzi, which is known as the Chagas disease. Chagas disease also the protozoa basically damages the meandric plexus, right? Of the esophageal wall also it destroys the meandric plexus, and also of the duodenal, colonic and the ureteric wall. And along with achalasia, there is also esophageal dilation grossly in Chagas disease. Okay. So one reason of the secondary achalasia is Chagas disease. The other reason is extraesophageal malignancies. These tumors can basically exert a mass effect or paraneoplastic effect, which can destroy the meandric nerve plexus, leading to achalasia. Other causes include diabetic neuropathy, amyloidosis, sarcoidosis and polio, all of which are degenerative to the meandric plexus. Now, achalasia is also seen with some genetic disorders such as Down syndrome and Algrove syndrome. Algrove syndrome is known as the AAA syndrome. Why so? The AAA are achalasia, which means the failure of LES to relax. Alicremia basically means there will be no flow of tears from eyes. And the other is adrenal insufficiency, which is basically due to the resistance to ACTH, adrenocorticosteroid thyrotropin hormone, right? Now, how does the patient present? The patient will present with progressive dysphagia to both solids as well as liquids. This is how you distinguish achalasia from any other obstruction. Obstruction can also happen because of any tumor, right? In such cases, in obstructive cases, there is primarily dysphagia to solids, not liquids. But in case of achalasia, the LES itself is not relaxing. That means the food cannot go from the esophagus to the stomach. So basically, there will be dysphagia to both solids as well as liquids, right? Also, achalasia is associated with increased risk of esophageal cancer, something to be remembered. Achalasia is basically a triad of three things: incomplete relaxation of LES, increase in LES tone, and aperistalsis. How do we diagnose achalasia? We can give the patient a barium swallow and do the radiological study, and this is how it will appear. Basically, this is known as the bird beak appearance, as you can see over here. So this is achalasia, the failure of LES to relax, and proximal to the LES, the esophagus will be dilated because of the food products and everything, solid, liquid and all. The esophagus proximal to LES will be basically dilated, right? Now, how do we diagnose this? We learned number one is barium swallow. We can also do manometry. Manometry basically detects pressure within the esophagus. So we'll see increased LES resistant pressure, and also we'll also see uncoordinated or absent peristalsis, as we talked about in the triad. This is all about achalasia. Now, how do we treat it? We can treat achalasia by surgery such as laparoscopic myotomy. Myotomy means like you are basically cutting down the muscles. And the next thing is pneumatic balloon dilation. This is the pneumatic balloon dilation. This is how you do it. Okay, basically this is the pneumatic dilator, which is inserted at the lower esophageal junction, the sphincter basically, and after it has been positioned, basically the balloon is completely inflated and the restore is the flow is basically restored. The other thing which we can do is endoscopic procedures, such as we can inject botulinum toxin injection over there. So botulinum toxin, what does it do? It basically cleaves down the snap snare proteins and it helps in muscle relaxation, right? So this is what we can do in achalasia. Revising it once very quickly. So achalasia is nothing but incomplete relaxation of LES, increase in LES tone, and aperistalsis, which we can detect by manometry and barium swallow. There is restriction of the myenteric or orebuck plexus of the esophageal wall. It can be due to primary secondary causes. Primary is idiopathic, secondary can happen because of Chagas disease, malignancy, diabetic neuropathy, or myelioidosis, sarcoidosis, or polio. It is also associated with Down syndrome and Algrove. Patients present with progressive dysphagia to both solids and liquids, difficulty in belching, and chest pain. And treatment is surgery or endoscopic procedures. I hope you all understood.